Very much, and it's an honor to be here. Thanks for the introduction. I'll just mention Tamara Ciccone works with me very closely, so I didn't hear her talk, but I saw a copy of it, so I hope I don't repeat some of the things that she said too much and bore everybody. It's a delight to be here again. I've been to Belgrade many times. The first time was in 1968. It was Yugoslavia at that point, and things were very different, and the country and the city keep changing every time I come here. It's much for the better. I mean, things have really improved. So I'm going to talk about aging, cellular senescence, and senolytics. Tamara introduced some of this stuff, but I'm going to really focus on the side of the early clinical trials that are underway. And as you're aware, I think probably Tamara mentioned it before, aging begins before conception. You're always aging. Down syndrome, for example, is a cellular senescence-driven disorder, and that's related to aging of the egg cell before it's even fertilized. So it's very clearly a cellular senescence-driven disorder. In fact, clinical trials are funded, well, the path towards clinical trials are already funded and maybe starting soon for adult Down syndrome. So we're all aging all the time. So this isn't just a disorder of the elderly. Now, I happen to be a clinical geriatrician and endocrinologist as well, and I got tired of prescribing better wheelchairs, walkers, and incontinence devices. So I went back to school and got a degree in biochemistry and molecular biology. So I'm both a clinician and a basic scientist, and my passion is to see if there's something we can do about these age-related disorders, which are currently very difficult to treat and very frustrating. So I think, as Tamara probably discussed, cellular senescence is a cell fate. It's like replication, differentiation, apoptosis, or necrosis. And any kind of cell can become senescent. It occurs across the vertebrates. It even occurs in some vertebrates and maybe even very, very low organisms like C. elegans. There's increasing evidence that senescence or a senescent-like state can occur in some cells. So this is a very general phenomenon, and senescence normally develops in response to damage of various types. It could be replicative damage, it could be early cancer development, it could be mechanical stress, shear stress, pathogens. There are 70 or 80 things that we know can tend to push a cell into the senescent cell fate. And these cells effectively lose ability to replicate, although they can reacquire replication potential. And they are metabolically active, and they're very resistant to dying. They're normally only killed by the innate immune system and certain aspects of the T lymphocyte system, CD8 T lymphocytes of various types. So they have to be removed by the immune system. I think probably, as Tamara might have mentioned, senescent cells can produce a senescence-associated secretory phenotype that involves production of various cytokines, chemokines, growth factors, proteases, and not just proteins, but bioactive small molecules like various bradykines, ceramides, non-coding nucleotides like microRNAs, circular RNAs, circular DNAs, mitochondrial DNA. And these may be even more important in what senescence cells do than the proteins. And senescence can spread to a great distance. So if senescent cells have formed, if they persist and they're not removed, they can spread elsewhere in the body, including shielded areas like the brain. So you can have senescent cells in a knee joint, and that can spread senescence to the brain, for example. So there's a lot of interlinkage of processes that can drive focal senescence with eventual development of systemic disease. So people with osteoarthritis, for example, which is a senescence-driven disorder, are much more likely than other people to develop Alzheimer's disease, which is another senescence-related disorder, earlier than other people. So there's a big interconnectedness amongst these states. So again, I won't go through it, but Tamara probably went through how we discovered the first senolytics. This was based on work originally done by Ned Sharpless. He was director of the National Cancer Institute. He published a paper in 2004 showing that if you calorically restrict mice, which extends their health span, you also delay accumulation of senescent cells. So there was an association between senescent cell number and health span, or the period during life in which individuals live free of pain, disability, they're cognitively intact, mobile, etc. That led us to ask, is there a causal connection or not? Is this just an association or is it causal? So Tamara and I, when we were in Boston, we started trying to develop ways of targeting senescent cells to selectively remove them, to ask if this was more than a causal link, and maybe if one day interventions could be developed, if it is a causal link, to clear senescent cells. So using a hypothesis-driven approach, we reasoned that some senescent cells have a pro-inflammatory, pro-apoptotic SASP, about 30 to 70%. The other 30 to 70% have a pro-growth SASP. But we wondered why those senescent cells that are killing cells around them survive despite the fact they're killing cells around them. Why didn't they commit suicide? So we developed mass spec data after we moved to Mayo with Izu, a very talented postdoc at the time, who's now faculty. And we asked, are there ways, using these mass spec data and very early bioinformatics approaches, are there ways that senescent cells, are there pathways that they defend themselves against the things that they're using to kill cells around them, at least that 30 to 70% that are pro-apoptotic? And we found there are at least 5 pathways, now we know there are 10, that these cells use to defend themselves against being killed. We used RNA interference approaches to identify key nodes. Tamara showed that slide. And then we used programs from the Broad Institute to look for agents that would target the key nodes that if hit by RNA interference would allow senescent cells to commit suicide. In other words, would kill senescent cells. So using that original mechanism-based approach, there are around 40 senolytic agents that have been identified. Since then, high-throughput screens have been developed, CAR-T approaches, vaccines, and other ways of targeting senescent cells. There are at least 70 conditions in preclinical models, that is, in human tissue explants or cultures, or mouse or rat or monkey or other models, that we know appear to be related to senescent cell accumulation and can be alleviated by senolytic agents. So what we've done is a lot of preclinical work, and we're at the point now where we're beginning and have done some clinical trials of these agents. We decided early on, although we identified a lot of senolytic agents, to focus on agents that are orally active and that have a history of use in humans or are natural products where the safety profiles were known, because we wanted to get to clinical trials quickly. We purposely picked agents for initial clinical trials that have a short elimination half-life. It takes a week to 6 weeks for senescent cells to form. They don't divide once they have formed. And we know that you can't introduce interventions that prevent senescent cells from developing, because you'll cause cancer if you do that. But if you get rid of established senescent cells, especially as they develop on more and more pro-apoptotic, pro-inflammatory, tissue-damaging secretory phenotype, you can alleviate dysfunction in preclinical models. So we wanted to use a hit-and-run approach, because we found out that it only takes a half hour to 2 hours of exposure to senolytics to allow senescent cells to kill themselves, and that takes 18 hours, but once it's started, it's irreversible. So it only takes a half hour to a 2 hour exposure. So we figured we could give these agents periodically, like once every 2 weeks or once a month, if there's a continued drive for senescent cells to form. So the way that we administer these drugs in the clinical trials is usually for a couple of days out of every 2 weeks, or a couple of days every month as the strategy, because we found that actually works better than continuous administration. And this way we're able to reduce off-target and side effects. And we purposely pick drugs that have, like dasatinib, that is a 3-hour elimination half-life and has been an approved drug since 2005. It's actually off patent in the EU now. And then certain natural products like fizetin. In mice, it's got a 5-minute elimination half-life. First pass. And the 3-hour second pass elimination half-life. So these drugs are gone very quickly. So we use a high dose administered quickly, periodically. So the NIH established something called the Translational Geroscience Network. They were crazy enough to allow me to be principal investigator of it first time around. But the initial group includes Mayo, Harvard, universities of Minnesota, Connecticut, Michigan, Texas, as well as Wake Forest and Johns Hopkins University. And now we're expanding to include a multi-site group in Los Angeles, St. Jude Children's Hospital, the Stedman Clinic in Colorado, Northwestern University, and others. And what we're trying to do is clinical trials in a coordinated way across all these sites. There are trials also beginning in Europe that this Translational Geroscience Network is engaged in. So there are 2 trials in Sweden, there are 2 in Denmark, there are several in Holland that are about to begin or are beginning, and there's a planned trial network in the United Kingdom. So one of the things that, and Tamara's in charge of this, one of the aspects of the facility of the Translational Geroscience Network is to centralize analysis of body fluids. So various blood fractions, urine, saliva, tear solutions, where we can get at cerebrospinal fluid and other kinds of analytes, as well as looking at biopsies and so forth. And one of the goals is to develop what we call Diagnostics. We're not interested in biological clocks. We're interested in things that would meet FDA criteria for the endpoint for a clinical trial. And there are 9 criteria we have to meet, some of which are on this slide. So just having a mere biological clock that gives you an idea of what the biological age of a person is not good enough. We need composite scores or measures that improve in response to interventions, that predict which intervention to use, and that predict clinical improvement with those interventions, phenotypic improvement, and that meet all the other things like scalability, applicability across ethnic groups, all of the usual kinds of things. So it's not good enough to just track biological age. We have to have things that are responsive to interventions. There are a number of things you might have heard that are biological clocks, but they don't respond to interventions. So that's not useful clinically. An early composite score we developed, and we're a long way further than this now, but this was the first published one, developed in humans, was in response to senolytics. And we found that combining a number of factors that are secreted by senescent cells in the blood, we were able to track responses to interventions and predict improvement. But we've got a long way to go with this. It's going to take 3 to 5 years, I think, before we're at the point of even thinking about approaching the FDA and having a CLIA certified kind of test. A lot of groups are working on this around the world. Big Pharma is working on developing Diagnostics. They've offered to sell their rights to this for $1. So they've got patents they're offering to sell the rights for $1. And the idea is to create an internet that everybody can run their website on, or build a highway that everybody can run their truck down. So it's in the interests of groups like pharma industry to have a pathway that the FDA will agree to as an endpoint for clinical trials, much like a blood pressure would be or a fasting blood sugar. Then they can develop their particular compounds that they're interested in based on that. So another interesting thing that we found is that these fundamental aging processes appear to be interlinked. Tamara talked about the pillars of aging or hallmarks of aging, and they're tightly interlinked. there are factors that go down with age that are what we call geroprotective, and there are factors that go up with age that are damaging. One of the things that goes down with aging is alpha Clotho. Clotho was the Greek goddess of birth. She's one of the three fake goddesses. She's the one who holds up the spool of life. She's the one you see in cemeteries looking down at the dead. That's to help raise them from death. She wears a cloak like this, and she's holding up the spool of life. So she's the goddess of pregnancy. And this protein was discovered about 25 years ago. It's a big transmembrane protein. It's produced mainly in the brain and the kidneys, and to some extent in fat tissue. If you overexpress it in mice, you get a tremendous increase in maximum lifespan. It goes down in diseases like Alzheimer's disease. If you make it go down in experimental animals, they get an accelerated aging-like state. And we found that when we give senolytic agents to patients with idiopathic pulmonary fibrosis, and we measured Clotho in the urine through the facility of geroscience analysis, that 20 out of 20 patients had an increase in alpha Clotho in their urine. So we're interested in not just things that are bad that go up with age, we're interested in things that are good that go down with age, so that we can express these things as a ratio. Because one of the problems you always have if you're developing diagnostics is, what do you express it as a function of? So if you express, say, a urine analyte as a function of creatinine or cystatin C, you're confounding the data with muscle mass. So what we want is to have ratios of things that go in one direction or the other with aging that we can use in ultimate composite scores. Beyond gerodiagnostics, we need to go beyond blood analytes, and we're trying to develop ways of incorporating demographic data, questionnaires that can be administered remotely across all the trials. Medical records, that's difficult to do in the US, but in France, it's not a Magna Carta country. The state owns your medical records. If you live in France, you don't. It's very different than the English-speaking countries that all go back to King John and the Magna Carta, where your health information is private. So the French have an advantage in developing some of this. And other things that could be incorporated in some of these scores are things like simple biometrics, certain tests that we can use AI approaches on, as well as looking at accessible body fluids. And then other things that are being developed in what we call healthy longevity clinics, which are starting in academic medical centers around the world. The one at Sheba University in Israel just opened 6 weeks ago. There's one in Singapore. Mayo's opening 2 of them. There's one opening at Stanford. There's consideration of one at Johns Hopkins. These will be evidence-based clinics where advice can be given to patients about gerotherapeutics, mainly telling people what not to do, not to buy stuff over the counter and not to go to sort of crazy clinics, but also to interpret with these patients results of tests that they get when they send their blood and have or get a kit from Amazon that tells them their so-called biological age. Again, most of which are garbage, but we have to have a way to tell patients this. But at least in these clinics, what's being measured in a standard way is things like AGEs using skin readers, advanced glycation end products, looking at vectoring of eye movements in response to signals using visors, one-lead EEGs in response to auditory signals, various parameters on the ECG that are predictive of some of these processes, skin wrinkling and 5-view facial recognition patterning, periodontal x-rays and looking at periodontal patterns, because those will predict Alzheimer's disease, for example, by about 8 years. And that's related to senescence around the teeth. So there are a lot of interesting things that are going to be included and in ocular convergence tomography, which is non-radioactive, where you can actually see groups of senescent cells in the retina which reflect what's going on in the brain. So the clinical trials, the trials are all at the moment for very serious conditions for which there are no good treatments, because ethically we're worried about risk-benefit ratio. In our view, it would be unethical to try some of these interventions in healthy middle-aged people in an effort to try to prevent them getting sick. So we're going after diseases that are very serious for which there are no good treatments because we don't know what the downsides are going to be. There are bound to be serious side effects. We don't know what they are yet. So there are now 50 clinical trials underway. Some of them are with senolytics, some are with other agents that affect fundamental aging processes, things like senomorphics. These are agents that inhibit the secretory state of senescent cells. Metformin, for example, and rapamycin-related drugs like sirolimus, everolimus, tacrolimus are senomorphic. JAK inhibitors are. Then there are some drugs that are both senolytic and senomorphic. They kill senescent cells to some extent or affect their secretory phenotype. IV zoledronic acid, for example, given for treating osteoporosis, is actually senolytic and senomorphic. Oral bisphosphonates are not. It has to be the IV form. So there are some interesting agents that are coming forward, and other things that are being looked at in these trials are NAD precursors, which incidentally could be very dangerous in older individuals because they can promote cancer development if there's an occult cancer. They might be very beneficial in middle-aged people, we don't know. Senolytics, on the other hand, why would you give them to a 30-year-old who's healthy and has no senescent cells? So this is why JR diagnostics are important. The FDA makes us, in those situations, show that the patient has senescent cells if they're in a clinical trial before we give senolytics. So there's going to be a lot of fine-tuning. I don't have time to go through what all the trials are. A few of them have been published already. There was an early trial for idiopathic pulmonary fibrosis, which is a senescence-driven disorder that's uniformly fatal. Some forms of it are partly genetic, some are acquired. It's a disease of fibrosis of the lungs related to senescence of lung alveolar cells. This was an open label trial, phase 1, so it's not placebo-controlled. There are a lot of learning effects. It could be entirely wrong. But we did this as a very early trial in a small number of people to look at safety and tolerability mainly. But the main thing is, those of you who've seen patients with idiopathic pulmonary fibrosis, that these people experience is frailty. And it's the frailty that kills them more than the respiratory problem. So they're dying of muscle weakness, falling downstairs, other aspects of frailty, more than they are of actual respiratory impairment. And so we measured frailty parameters in these people because we knew in preclinical models that these agents might target frailty. And we found that, for what it's worth, in an open label trial and all the biases there, that 6-minute walking distance was improved, 4-meter gait speed, chair stands, and short physical performance batteries. So that's led to more trials that are phase 2A, placebo-controlled trials in idiopathic pulmonary fibrosis that are about to begin. And it also led to 2 trials called AFFIRM, looking at frailty in elderly women. So women with a gait speed of less than 0.6 meters per second have a 50% 2-year survival. It's much worse than most cancers. So a woman over 70, if they're walking at the speeds that Tamara walks at less than 0.6 meters per second, that's a 2-year, you're looking at a 2-year mortality rate. So those trials are underway. We did an early target engagement trial in patients with obesity, diabetes, who were younger and had incipient renal failure. These patients' fat tissue is filled with senescent cells. Senescent cells contribute to the insulin resistance that they have. Things like TNF-alpha are being produced, and certain non-coding nucleotides that interfere with insulin responsiveness. And they've got many kinds of cells in adipose tissue in these people, especially subcutaneous adipose tissue or senescent. So we did a biopsy at day 0, biopsy at day 14. They got 3 days of senolytics on day 0, 1, and 2. So these drugs are cleared very quickly. They had the second biopsy done 11 days after the last dose of senolytics. The drugs are completely gone by 36 hours. But we found indicators, and there are no perfect markers of senescent cells, that senescent cell burden was decreased, even though it's a very small study, significantly. We found that inflammation marked by pro-inflammatory macrophages was reduced, and fibrosis was reduced, marked by crown-like structures. And that was the trial, incidentally, that we derived that JR Diagnostics score from. So that went along with the extent of decrease of senescent cells, went along with that JR Diagnostics score. I know I'm over time. I'll try to finish quickly. Oh, okay. There are trials underway, and I think Tamara mentioned them. There are 3 trials underway for coronavirus, and we've got minimal risk studies for long haulers. So we're finding that long haulers is associated with senescent cell accumulation if there's brain fog and if there's weakness. And the extent of brain fog and the extent of weakness in long hauler syndrome are correlated with senescent cell burden, looking at a variety of parameters in studies we haven't published yet. But in established coronavirus, we had various model systems where we looked at this. We find that coronavirus, like other viruses, drives cells to become senescent. In the case of coronavirus, it's through TLR3. Senescent cells take up 3 times more coronavirus than normal cells. They mutate the virus. So senescent cells mutate both RNA and DNA viruses. They've got a porous nucleus. RNA viruses and even just regular RNA make it into the nucleus in senescent cells. So the various nucleotides that are in the nucleus that RNAs are normally shielded from act on RNAs in senescent cells. And so Clemens Schmidt at the Charité in Berlin found that in MERS, variants were being produced, and more recently he's got evidence that some of the variants of coronavirus are occurring when the virus gets into senescent cells. Furthermore, senescent cells produce factors that upregulate the S1 antigen in adjacent cells and interfere with antiviral defenses like IFIT, M2, and 3. So it tends to be patients who have senescent cells who do badly with coronavirus. People who are obese, people who are diabetic, people who are elderly, people with chronic obstructive pulmonary disease, people who've had chemotherapy or radiation. These are the people who do badly, and they're the ones with senescent cells. So that's led to these trials that are underway. A different trial they weren't using quercetin, as they didn't realize it was senolytic, I think, when they did the trial. But they did a controlled trial of quercetin at the kind of dose that we're giving along with dasatinib in 76 patients with coronavirus versus 72 standard care female outpatients. And they were younger patients, but they found significant reductions in hospitalization, need for oxygen use, and need for ICU care. Our trials are double-blind. They're underway at the moment. We don't know what the results are. One should be finished fairly soon. We've got a big one that's occurring across nursing homes across the US as well, with senolytics for coronavirus. And as you know, there are new variants coming in all the time. The one just came across from Africa recently, a new epsilon variant, and that's totally resistant to existing vaccines. So we need things other than, and it's resistant to Paxlovid too. So we need agents that are in addition to antiviral agents and vaccines for something like coronavirus, or it's going to continue to be epidemic. We are looking at, and this is funded by the NIH, but also crowd-funded, in people with who've got HIV, chronic HIV syndrome, or persons with HIV. These people have continued viral infection at a low level despite taking antiretrovirals. They get much earlier Alzheimer's disease and osteoporosis and diabetes and have an accelerated aging state compared to the general population. They have a lot more senescent cells. And that tends to track with the severity of chronic HIV syndrome. So a trial is beginning comparing senolytics to metformin in this disorder. There are 3 trials for Alzheimer's disease and 1 for mild cognitive impairment that are underway. The one for mild cognitive impairments at Harvard, and then the other ones are multi-center trials. There are trials underway to look at frailty in survivors of treatment of cancer before the age of 10. So this is done with St. Jude. So we know that if you give cancer treatment, alkylating agents, anthracyclines, or radiation, that induces senescence. And it turns out that some people who've had cancer treatment before the age of 10 are developing an accelerated aging state at between ages 35 and 45. They're developing Alzheimer's disease at ages 40 and 45. They get second unrelated cancers, diabetes, osteoporosis, and they're dying, and they look like they're 70. we found that this syndrome correlates with senescent cell burden in skin biopsies. So a trial comparing 2 different senolytics plus placebo is being conducted in these children in collaboration with St. Jude. We're developing trials in what's called a 1-2 punch approach for cancer. So if cancer cells are not killed by chemotherapy and radiation, they're converted into senescent cells if people go into remission. This is especially true in glioblastoma, triple-negative breast cancer, and certain other really serious cancers. We just published a paper showing in preclinical models of glioblastoma that if you follow chemotherapy and radiation with senolytics, you can extend the period of remission. So we're planning an emergency clinical trial. The paperwork's just going into the FDA to look at people with stage 4 and 5 glioblastoma who are in transient remission. As you know, they all die, usually within a year. They get a period of remission after temozolomide surgery and radiation that's typically 2 to 3 months. But the disease always comes back, essentially. And the same with triple-negative breast cancer that's immunotherapy resistant. So we're starting trials in those conditions to look at alternating senolytics with these agents because we know that the cancer cells that aren't killed are driven into a state of what we call TIS, or therapy-induced senescence. They escape that, they come back as radiotherapy-resistant and chemotherapy-resistant cancer cells. So, we're hoping against hope that we may see something with this. Temozolomide was the last advance that did any good for glioblastoma. That was back in 2005, and it added maybe 1 month to 6 weeks to remissions. And other than that, there's been really no progress with glioblastoma. We're looking at space travel. So we've been working with SpaceX and Axiom. We studied the astronauts before and after launch. We had to go down to Cape Canaveral for the launch, and I was blown backwards about 3 meters when the thing took off. And we find that astronauts, when they return to Earth, have an increase in senescent cell burden. And this is probably partly related to zero gravity, which deforms the nuclear and cellular membrane and can induce senescence. High G forces, which do the same. Cabin atmosphere, and most importantly, space radiation. Now, all the flights that have been done so far have been within the Von Allen belt, including flights to the moon. There's a reason we haven't gone beyond 2,000 kilometers, and that's because of cosmic radiation. So when they talk about delaying the Mars mission, they're delaying it because of cosmic radiation. Cosmic radiation involves hydrogen, helium, and selenium, 1, 2, and 3 on the periodic table, traveling at the speed of light. So we worked with Brookhaven National Labs and the cyclotron, and we found that it just takes 0.5 grays of the equivalent of solar flare radiation to cause a cell to become senescent, where it takes 20 grays of X-ray or gamma radiation to make a cell senescent. So we absolutely have to solve this problem if there's going to be spaceflight, and we're also worried about pilots and aircrew. So as you're probably aware, pilots and aircrew are dying earlier than the general population of Alzheimer's disease, glioblastoma that I mentioned before, triple-negative breast cancer, prostate cancer. And we don't have good evidence about it yet, but there's a possibility this may be related to some of these same phenomena if they're flying at 10,000 plus meters. Examples of some other trials that are beginning is to try to restore function of organs before transplantation. We know that if you transplant organs from older individuals to younger individuals, there's spread of senescence from the transplanted organ. We know in preclinical models, we did heart transplant studies with the group at Harvard in preclinical models, and we found that hearts from older animals spread senescence to the younger animals. And it isn't senescent cells escaping the heart, it's this spread of senescence. So the individual's own cells become senescent at a distance. The senescent cells produce mitochondrial DNA that acts on dendritic cells and draining lymph nodes and causes graft versus host reaction. Surgeons all know this. They will not use kidneys from donors over age 50 unless they're live-related donors in the US. So we're throwing away 35,000 kidneys a year of people who die in car crashes and are donating organs, even if the kidneys look good. You know, Carl Nath can tell you about a lot of that. With islet transplantations, it's even worse. The surgeons won't use islets from people over the age of 45. So what we're trying to do is, while organs are in life port systems, because we found we could do this in preclinical models, is to treat with senolytics to clear senescent cells from the organs. These are preclinical studies, but they're with human samples that are being discarded at the moment to see if we can eventually rehabilitate these organs and use them. There's a parallel trial going on in Holland now, in Groningen in North Holland, looking at liver transplantation. There are trials of about to begin with creams for diabetic skin ulcers, because there looks like a lot of promising evidence that senolytics can partly heal those in creams that penetrate to the right depth. We're looking with State University of Colorado at enhancing wool production in sheep. So Argyle sheep, which are very valuable, produce wool from the ages of 2 to 5 years. They live 12 years, but it's 2 years before they start producing wool. They slaughter them at age 5 because the wool's no good. So we're developing shampoos because we're finding that we can improve hair quality, thickness, and color with these kinds of agents. And so this, if it worked, and I'm touching wood, if it worked, it would really help the Andean countries in South America that depend on a lot of wool production. And, that would mean a shorter amount of time, they get more time per animal of wool production, and, the relative amount of time the animal's alive producing wool would be increased. I mentioned the trials for Down syndrome. Trials are about to begin for heart failure with preserved ejection fraction. Preeclampsia seems to be a senescence-driven disorder. So the placenta develops senescent cells, and they're what produce the factors that drive the baby through the birth canal in the last 5 days of pregnancy. A group at Mayo, who you know very well, sitting in the front row, found that preeclampsia appears to be related, and the vascular, and it's, you can speak more about it than I can, but the vascular hyperreactivity, the hypertension, and the issues with fat tissue vascular induction by fat tissue of vascular hyperreactivity appear to be related to senescent cells. And people with preeclampsia are dying earlier of age-related diseases in other groups, and their second pregnancy they're going to get it, but Vesna can tell you all about that. There are trials beginning at University of Minnesota for sepsis syndrome, and post-chemotherapy syndrome in older adults are beginning at City of Hope in Los Angeles. There's a trial funded now for wet macular degeneration of senolytics, because that's a senescent-driven disorder. So in conclusion, persistent senescent cells appear to cause inflammation, fibrosis, progenitor cell dysfunction. Didn't have time to go into all these things. You don't want to interfere with generation of senescent cells. You do want to get rid of persistent senescent cells that the immune system hasn't cleared, because if they're not cleared, you get more and more senescent cells forming because senescence spreads. Senescent cells produce factors that inhibit the immune system. So they produce things that upregulate IL-17 and that downregulate IL-23 and affect the ability of T lymphocytes to work properly, and that reduces cancer surveillance. They inhibit the function of dendritic cells directly through mitochondrial DNA. They prevent macrophage diapedesis through producing IL-6. They greatly impair NK cell function. It's normally NK cells that clear senescent cells. 80% are cleared by NK cells. So once they're beyond a threshold, they start poisoning the immune system, and you get a spiraling upwards in abundance of senescent cells. It looks like hit-and-run approaches may be most effective. They appear in preclinical models to delay or alleviate multiple disorders, but we don't know if they work yet in humans. Until carefully controlled clinical trials that are regulated, by groups like the FDA or EMA in Europe, until those trials are done, physicians should not be prescribing these agents and patients shouldn't be taking them. And we're starting with very serious diseases to begin with, and if these things work, and I'm touching wood, and if we don't have a lot of serious adverse events that are related to the drugs, we'll try to march backwards towards prevention and earlier diseases. So I'll conclude by thanking a lot of people, especially Tamara in the front row and Izu. We worked together on finding these senolytics. And then, Carl and Vesna and others who are here have done a lot of this work and been great partners. I assume, Carl, you spoke about the AV fistula stuff?
Yeah.
Okay. So thank you very much, and sorry for going way over time.
Thank you for this wonderful, inspiring lecture, and I expect there would be questions from the audience. So please don't be shy. So please.
Hi. So I'm actually pretty interested in how do you think autophagy and senescence play with each other? Is senescence a failure of autophagy, or does senescence lead to a failure?
Both. So there's an age-related increase, especially in sicker individuals, of mTOR, which inhibits autophagy. That's concentrated within senescent cells. So senescent cells have 3 times more mTOR than normal cells. They produce a lot of proteins. They're very big. They have failed autophagy. They produce protein aggregates and misfolded proteins. So there are some people who believe that most beta amyloid tau synuclein are produced by senescent cells. And conversely, if you take tau, alpha-synuclein, or amyloid and expose senescent cells to them, expose normal cells to them, they become senescent. So it seems to work in both directions. All these fundamental aging processes appear to be interlinked.
If you force express the mediators of the autophagy pathway, are you going to be able to reverse senescence or not?
What you do is you inhibit the secretory phenotype, and you probably reduce to some extent the spread of senescence. And that might allow, but now some of the inhibitors of autophagy, if they're given at the wrong dose, inhibit the immune system, and that makes things worse. So you've got to give very low doses. So if you're giving rapamycin, the dose that's given is way below the normal immunosuppressive dose, but still there's some immunosuppression. But because of that, that may allow the innate immune system and parts of the adaptive immune system to begin to clear up senescent cells. So you do find, after continuous administration of rapamycin, a decrease in senescent cell burden as well as a decrease in the SASP. So now it looks like it's possible for certain age-related disorders to give rapamycin for, a month and then stop it for 2 months, and then a month and stop it, and it may be related to this process.
Professor Lawrence?
Do you think that de novo lipid synthesis inhibitors could be effective?
The which?
De novo lipid synthesis
De novo lipid
inhibitors.
synthesis inhibitors could be effective.
There are a lot of agents that are turning out to be senolytic. They're possibly amongst them. So one of the things senescent cells do is they have a Warburg shift, like cancer cells. They're very much like a cancer cell. And part of the way metformin works in senescent cells is partly through that, but it also inhibits the secretory state of the cells, and especially the nucleotides they produce. But senescent cells do tend to accumulate lipid. They can't utilize lipid. They have to utilize glucose. They cause factors to be produced that activate CD38 on macrophages that make NAD go down. So decreases in tissue NAD occur in parallel with increases in senescence. Conversely, decreased NAD causes ROS to be produced, which makes cells senescent. So senescent cells can't utilize fatty acids properly, and they accumulate saturated fatty acids especially, and you can actually see them in them. The kind of senescent cells that develop around, like in the ependyma of the brain, they actually look like fat cells, but they're ependymal cells. They have so much in them. So Deanna York published that back in 2018, I think it was.
Carl?
Jim, that was fantastic. What I think is particularly insightful and could have a rich payback is your strategy in cancer cells, because you're using senolytics in a complementary fashion to decrease the sequelae of the disease. When Dr. Schwartz spoke yesterday, a statistic that he mentioned that struck me is that the prevalence of hypertension in the United States is approaching 50%. And given hypertension being a primary traditional risk factor for heart disease and cardiovascular disease, the baseline is enormous. Do you know, and based on the work that Vesna has done, do you know if there's any interest in clinical trials for senolytics in hypertension?
I think hypertension is being looked at, but it's not so much I think Vesna's trial, when she gets to it, would be very important, because there you've got an extreme hypertensive related syndrome. So it would, for disorders where there are existing agents, and they're not immediately life-threatening, it's a little bit early to be because anything that sounds too good to be true is. And, all of us who've done clinical trials, the chance of a phase 2A trial is working, no matter how good the preclinical data look, is between 5 and 30%. So most of them fail. And that's why in the Translational Geroscience Network, we're looking at multiple drugs, multiple lifestyle interventions too, like resistance exercise. And we're looking at them, and nutritional interventions. And we're looking at them across disease states in parallel rather than in series, because most of the trials will fail. So I think that's another thing. If you're talking to your patients and they ask you about these trials, tell them the chances are most of these trials will fail early on, because if public expectations are too high and the first few trials fail, the field will die. So we have to be very careful in messaging about that, I think.
Just, just to put into perspective metformin and its xenomorphic effects, I think metformin has been shown to be useful in disease entities that are above and beyond hyperglycemia and diabetes. And I think the example that really stands out is a trial of metformin to prevent gestational diabetes. And it actually failed to prevent gestational diabetes. However, they look into some other outcomes and show that actually metformin prevents preeclampsia. So I think from that angle, multiple studies looking into positive effects of metformin in disease entities above and beyond diabetes likely, at least in part, are mediated by its xenomorphic effects.
Right, and we know that metformin does other things consistent with that. For example, flu vaccine responses are improved by metformin. So we're very interested in what we call resilience trials. So that's things like how quickly does a wound repair after surgery? Does a patient get delirium after surgery? Does a patient have a good response to a flu shot? So in all these trials, we're intending to measure vaccine responses to flu shots in the autumn, because that's a geroscience measure. Metformin use is also associated with decreased Alzheimer's disease risk. It's actually people on metformin, there was a large trial in the United Kingdom. It's sort of an open label trial and retrospective in some ways. But they did find that patients treated with metformin as opposed to sulfonylureas lived longer. Not only that, the patients with diabetes on metformin live longer than people without diabetes not on any drugs. So, a lot of these geroscience interventions, and another example is the SGLT2 inhibitors. They're doing a similar sort of thing, because you want to get insulin doses down as far as you possibly can, because insulin drives senescence. So, but the SGLT2 inhibitors, when you look at what they're doing, there are all kinds of downstream effects on Alzheimer's disease, osteoporosis, just risk of infection, fatalities from coronavirus, the list goes on and on. Same with IV zoledronate. So, Jim Edwards and Graham Russell and Chaz Buntra at Oxford have 20 years of data showing that zoledronate, which we know is both senolytic and xenomorphic, we just published that with them and Sandeep Khosla, is associated with greatly decreased risk of Alzheimer's disease, decreased risk of diabetes, decreased risk of cancers, and increased health span. So it's quite remarkable. Conversely, there are geroscience interventions that can be bad if done too much, like resistance exercise appears to be very helpful and everybody says it's a panacea, but you do too much and it can make things worse. It can cause osteoarthritis and bone fractures. And actually the US Navy is funding 4 clinical trials of senolytics for people with osteoarthritis, because the main reason they cannot field marine units and manned ships, 70% of the inability to field marine units or manned ships, is because of osteoarthritis due to injuries in the training camp or behind the lines. So they found even in Iraq that 70% of the inability to field Marine units wasn't because of bullet wounds. And the injuries that caused absence from the battlefield were when the Marines were training in their camps in the rear, and it was from microfractures and osteoarthritis. So the Surgeon General of the Navy himself is funding these trials.
Okay, please.
Okay, so very interesting presentation. I'm a medical oncologist and I work with breast cancer. So I have a couple of questions. Actually, just wanted to point out that we do and we treat with early breast cancer with bisphosphonates, let's say. So it actually has been proven that the risk of relapse is going to be reduced.
And the IV works better than the oral too.
Yeah, we are giving only IV. Every 6 months, 3 years. So it is proven in the clinical trials. But honestly, I wanted to ask, because you said that you have clinical trials regarding breast cancer.
We're planning them.
You're planning.
And I can't talk about them too much because we're using an entirely new drug for...
Just asking for the concept. So from your point of view, what would be the better? Speaking about the methodology of clinical trials, I assume you're going to start with metastatic breast cancer. But speaking about the senescence, and the theory of senescence, we have triple negative breast cancer with very high risk of relapse, meaning that they are going to relapse in the first years. Yeah,
but these trials, not to interrupt you too much, but they are for triple negative that's immunotherapy resistant.
More interesting is the case that hormone receptor positive breast cancer are going to relapse after 20 years.
Right.
And that theory is actually connected with senescence. And nowadays in metastatic breast cancer, we treat patients not only with chemo, immunotherapy, we do have CDK4/6 inhibitors, which are very important for the cell cycle. So just an idea to think about. Because
and what we're doing with the glioblastoma trial is it's during the period of remission. But there, you see, the breast cancer thing, you're talking about remissions of 10 or 20 years, so it's hard to do the trial. With glioblastoma, we know every single one of them is going to get it back. And we know the period of remission is going to be 2 to 3 months. And nobody is currently doing any trials during that period of remission. So there's a lot of competition for trials during, once it's relapsed with radio and chemotherapy resistant glioblastoma, when really things are too late. So this trial is actually going to be one of the first ones. So we're trying to come up with a framework with the FDA that'll be right to allow us to do it in apparently asymptomatic individuals who are in late phase of remission.
More, oligodendroglioma and the grade 3 are at least at one point are going to evaluate in glioblastoma.
Right.
So maybe to go back one step and think about that.
Yeah.
Okay, there was someone in the back also. Yes, please. Yeah, you. Yes.
First of all, I would like to thank you for this lecture. It was a very informative overview of all the work being done. And I was just thinking, because I'm a neurologist and we are talking here about their age-related disorders and geriatric science, but has anybody looked specifically, like, for example, in young onset Alzheimer's disease, because these people get sick earlier, around 50 to 60 years of age, maybe the senescence process is even more involved in that kind of pathology?
The initial trials are just with later phase Alzheimer's, and there is a trial with mild cognitive impairment, as I mentioned, that's late stage mild cognitive impairment, early Alzheimer's, MoCA, like with a MoCA scale that sort of overlaps at Harvard. But the other neurologic trials that are being contemplated at the moment are for lateral cord compression, spinal cord disease, because we know that that's related to a fibrous plug, that it comprises senescent cells that prevents neural outgrowth. Neuromyelitis optica. There are trials planned for Parkinson's disease related to the synuclein, and there are trials planned for, there's a trial partway through actually being planned in Houston, looking at ALS, but especially where you can find a lesion. What they're going to do is apply it locally, and then look at the opposite hand. So they want to do it in the left, the left region, the left posterior frontal region, and look at motion of the hand.
Yeah, I think Yeah, it's all very interesting, and I think you're just really interesting group of people that get neurodegenerative diseases earlier in life. So there are not a lot of them, but it's interesting.
Well, these childhood cancer survivors do. They are getting one of the main reasons of their dying is Alzheimer's disease.
And one more thing. I mean, the end goal of this pharmacotherapy is, of course, prevention in people that don't yet have the disease, which are
that'll be a long time. Yeah, that'll be a long time.
But did anybody done any kind of research about non-pharmacological interventions that can reduce senescence?
Yeah, things like resistance exercise can, if they're done the right way. There are some diets purportedly, but some of them have real trouble. Like the ketogenic diet, if it's done the wrong way, looks like it may be causing more harm than good. So if it's intermittent, it may be safe. If it's continuous, there were a couple of papers out just recently saying that it's very bad. Then there was this stuff out about the taurine diet and all these kinds of things. That's deficiency of taurine, basically, and that appears to be related. Fucoidan, there's a paper, I don't know if it's already come out or about to come out, but there are a number of dietary sort of things.
So let's have one more question, and please.
Very interesting talk, Marie Hogan from Nephrology at Mayo Clinic. As a female in her 5th decade, I'm most interested in therapies for menopause and loss of ovarian function over time as natural physiology. Have you any comments to make on, I know that the NIH is very interested in gender changes, and there's a huge resurgence of use of hormone-related therapies, and there must be a biology here related to senescence.
Yeah, and indeed, senolytics have very different effects in female than male experimental animals. We don't know in humans yet, so there may be senolytics that are more effective for females than males and vice versa. So the NIH, that's actually a requirement now of the NIH, as you're aware. So in all these trials, we're looking at that across the Translational Geroscience Network. And there are going to be, I think, huge differences between pre- and postmenopausal women too. And for osteoporosis, for example, these drugs don't work in perimenopausal osteoporosis, but they do work in age-related osteoporosis.
And Jim, I think it's important to mention that we are now part of the 254 grant, that several centers around the United States, we are creating the atlas of senescence in different tissues, and also female reproductive organs will be involved, including ovaries, including uterus, including placenta. So I think it will be important to see as to whether natural process of senescence is engaged in menopause and how it varies across the different decades of life. So
and then we were talking about cancers before, and one of the really bad ones is serous ovarian cancer. I mean, it's usually found at stage 3 or 4, and the person's already basically dead by the time you've found it, or there are any symptoms. So I think that'll be another one where these because it's clearly related to, it's not our data, but there are other data that were just presented in Vienna where I was about that.
So I think that we should not exceed our discussion. I'm sure that there are many questions, but time is running out, and to be honest, we have dinner reservations in 3 minutes. So. We are still not Scandinavian countries, so they will hold the tables for us, but still. So I thank you all for coming at this late hour, and this is just
thank you.
A couple of souvenirs from School of Medicine.
Thank you very much.
As a memento of this event. And we have recorded this lecture. I hope you don't have a problem with posting it.
Do you have a problem? Okay.
Okay. So for all of you and all the others, so the lecture will be on the University of Belgrade website. We'll have the link, so please they can check it out later, and then searching for professors' papers for some answers. So thank you all for coming, and wish you a nice weekend.
Thank you.
Thanks.